Mm.
All right, I'll have to call customer service. I already paid $15 a month for this, and I'm still down to 40 minutes. I want my money back.
I don't blame you.
Okay, let's go back to chapter 37 under sepsis. All right, I'll try to keep this simple. Of course, most infections start as local, right? Are we?
Yes.
Yes.
Yes, we're recording. All right, so this figure here tells you the progression of sepsis to septic shock. So most infections start with a local infection. So let's say it's a pimple. The pimple happens to be located between your rectum and your scrotum. Okay, I'm talking about Mr. Felitas. Okay, so let's say Mr. Felitas developed a large pimple between his rectum and his uh, groin, that area right there. So is that an easy place to keep a wound clean?
No.
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 Not the best place to have a pimple. All right, so let's say long story short, he got an infection on that pimple, and because it's in a really bad place, it there's an abscess now, and then it became a systemic infection. And after that, it progressed into early sepsis, which is now SIRS. And then he went into full-blown sepsis, and then went into septic shock, and then died. These are the stages of septic shock. As you can see, is there a particular stage that is the equivalent of other forms of shock, other types of shock? Meaning, can you say that, oh, this is initial stage, and this is non-progressive stage, this is the progressive stage? Do you see a pattern that coincides with the other stages? Well, the answer is no. Okay, I'll also show you when we get to these stages right here, they follow a different pattern, which will again be the reason why sepsis has a high mortality. It's not only difficult to treat, but the symptoms, especially when you go between sepsis and septic shock, the symptoms here can be very deceiving. So here it explains the stages here. So local infection, no systemic symptoms yet. And then of course, once you got a systemic infection, then you'll have systemic signs. The signs and symptoms, by the way, is not um, listed in this chapter. It's listed under burns, which we will do at our next class. Okay, so if the patient doesn't receive antibiotics or the antibiotics are not effective to the infection, to the current infection, then the patient goes into SIRS. Okay. Um, of course, the what can you say about the pattern of the infection? So let's go back to um, the other stages of shock, wherein we had initial stage, and then we had non-progressive stage, and then we had the progressive stage, and then we had the refractory stage. And this is the mean arterial pressure. What can you say about the pattern of the mean arterial pressure as we progress through the stages of shock? Miss Clarine. So let's say this is your MAP right here. What will be the trend of your MAP as we go from initial to refractory stage of shock?
It will decrease.
Okay, so it was easy to see, right? We can clearly see whether or not our patient was getting better or getting worse because you can see from the MAP, if you looked at the table, there was a drop of at first 10 to 15 and then 15 to 20, right? From baseline. So it was easy to see. You can see exactly, you can evaluate whether or not our treatment is getting is it making the patient better or worse because we can see it from the MAP. And of course, if we look at also the trend for our lactic acid level, what will be the trend for lactic acid?
Opposite, right?
Yeah, opposite. So if this is the lactic acid right here, it will be as we go through the stages, it will be go
Higher.
up, right? And it was clearly easy to see. Now let's see what happens in sepsis. So initially, it follows the same pattern. We can clearly see if the patient's going bad, the patient's going bad. So here, remember what happened in anaphylactic shock and also in neurogenic shock. There was vasodilation, correct? There is also vasodilation here happening in sepsis. This is in response to the severe inflammation resulting from the infection. So the infection here triggers a lot of cytokines, inflammatory cytokines, specifically interleukins 1, 6, tumor necrosis factor. So if you remember these cytokines, these were the same cytokines mentioned in chapter 17 under organ rejection. Do you remember?
Yes.
Yeah, okay. So these inflammatory cytokines are responsible for stimulating the T lymphocytes, right? As well as the B lymphocytes. So in summary, they trigger your immune system. They're released though in massive amounts here produce if they're in a larger than normal amounts, they will cause widespread vasodilation and blood pooling. So if there is now, what happens to your afterload here? Is it increased or decreased? When you have widespread vasodilation,
Decrease.
it will decrease your resistance or your afterload. As a result, what happens to blood pressure?
Um, Decreases.
It will drop. So here, the patient has mild hypotension, low urine output, and increased respiratory rate. So these are all are okay. I mean, I'm not saying okay, but I mean, the pattern is predictable, right? Of course, the patient is getting worse. So we will see a hypodynamic state, meaning the patient goes hypotensive during this episode here, during early sepsis and SIRS during this stage. Okay, so the patient has fever. So yeah, we can see that they are going bad. Also, some minor changes in this stage is we have this is still part of the severe inflammatory response. There is now inappropriate clotting, and you can see later when we go to septic shock, this patient actually goes into DIC. But the early stages of DIC begins here at this stage, although it's not widespread yet. You do have microthrombi formation, meaning the platelets start to clot for no reason, meaning you have no injury, but then yet your platelets are forming clots. Okay, no, this is not in response to normal endothelial or vessel injury. Okay, so these tiny clots just start to form, and of course, they will begin to block small capillaries, small arterioles, okay, contributing to the hypoxic condition. Now, as we go into further down into sepsis, the problem is, can somebody read this, please? Miss Wenister?
Unfortunately, this early hypodynamic state has a relatively short duration, and indicators are so subtle that the condition is often missed or misdiagnosed. When early sepsis and SIRS are identified and treated aggressively at this stage, the cycle of progression is stopped and the outcome is good. When sepsis and SIRS are not identified and treated at this stage, they progress and become much harder to control.
Okay, very good. Who is there 24/7 at the bedside?
The nurses?
The nurses. Okay. Do you expect doctor to catch this state here when this occurs?
No.
Typically, no. So when the doctor makes rounds, they may totally miss that time. So here, if we put this as infection and local, let's say local, and then systemic infection, and then let's say this is now early sepsis slash SIRS. So they follow the same pattern. So initially the patient goes hypodynamic, but only for a short time, meaning plus what did we give the patient? So let's say this is day 1, this is day 1, this is day 2. So on admission, what did we give the patient? Because they came for an infection. What did we give Paul in the ER?
Antibiotics?
Okay, very
Antibiotic.
good. So Paul received antibiotics. So what would you expect? So he was given antibiotics right here. So of course, what will you expect to happen in the next 2 days? What will happen to his white blood cell count, his fever?
Will it
It
decrease?
should decrease.
It should improve,
Decrease.
right? Okay, so let's continue. So it says here on this stage, the hypodynamic stage, meaning the time that the patient's blood pressure drops is very short. It is only about several hours. It doesn't reach a whole 24 hours. So if we miss this part and look at what happens, and this, by the way, are the criteria for SIRS. The doctors watch these to help us detect if the patient is going into severe sepsis. So these are your criteria. All right, please read on your own. Um, the the these are typical of an infection. So let's say in Paul's case, he has um, an infection. These we can understand, right? Because he has an infection. Of course, we expect those to happen for somebody with a infected pimple in the perineum. However, do these signs here make sense? Do you see these normally in somebody with an infected pimple?
No.
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 Why would the platelet drop? Why would there be absent bowel sounds? Why would your kidneys show injury or signs of failure? Why would your liver increase bleeding time? Okay, look at this. Why is there hyperglycemia in the absence of diabetes? Okay, so what's happening to blood flow to the GI tract, the kidneys, the liver, and even the pancreas?
Blood flow decreased.
Right. So these are
Decreasing.
right. So this is now evidence that there is anoxia to more than one organ now. So the hyperglycemia here there's two explanations here. One is if there is less blood flow to the pancreas, will it release normal amounts of insulin?
No.
No. So this will explain why the patient has hyperglycemia, even if they're not diabetic. Another explanation, of course, is this patient is under stress, right? They're sick. So, of course, cortisol levels will rise. That will contribute also to the hyperglycemia. Now, look at this stage here now. So, as the patient gets worse and goes into severe sepsis, look at DIC. So, we started with microthrombi formation minor earlier. So look at the microthrombi formation here in severe sepsis. So this is now DIC. So now you have, this will explain your thrombocytopenia, your platelet counts drop because what's happening to the platelets?
They're
They are
decreased.
forming, yeah, they are forming clots. So that's why your platelet count drops because where are they going? They are clumping together, causing, forming blood clots. Okay, so this is now DIC. And of course, in addition to that, clotting factors are also being used. I mean, you discussed DIC last semester, right? This is under chapter 40. This is under your bleeding disorders. So DIC starts, so this will add to the mortality in septic shock. Okay, so on top of septic shock, which will kill you, DIC will also kill the patient. It's just a matter of which one will kill the patient first, DIC or the septic shock. Somebody read this, please. So we are obviously getting worse, right? Thank you for reading, Ms. Gonzalez. The highlighted paragraph. It's like Jennifer's not here. What about Chantel?
Despite the severity of this stage and the fact that it may be present for 24 hours or more, it is often missed. One of the reasons it may be missed is that a cardiac function is hyperdynamic in this phase. The pooling of the blood and the widespreading capillary leak stimulate the heart, and cardiac output is increased with more rapid heart rate and an elevated systolic blood pressure. In addition, the patient extremities may feel warm, and there is little or no cyanosis. Even though the patient may look better, the pathologic changes occurring at the tissues level are serious and have caused significant damage. The white blood cell count at this time may no longer be elevated because prolonged sepsis may have exceeded the bone marrow ability to keep proceeding and releasing new mature neutrophils and other white blood cells. The white blood cell count may be extremely low, especially the segmented neutrophils.
Right. So to illustrate that, what's happening here is, so we were here at SIRS or early sepsis. Once we hit severe sepsis, the patient's blood pressure improves. The patient becomes hyperdynamic. So this stage here now is the severe sepsis. The patient becomes, or momentarily, they become hyperdynamic. So again, Paul was given antibiotics here. Here, we continue the antibiotics. So let's say this is day 3. How would you interpret this? How would you explain this change when the patient is getting antibiotics? Would you say, is it a rational conclusion to say that they're going bad when this happens, when they're on antibiotics? What is your, what would you know, your natural inclination be? What would be your inference? Is the antibiotic working or not?
Yeah, you think it's working.
Absolutely. Why would you think, you know, it's not working? The patient looks better. They feel warm. Here they feel lousy here during the early stages of sepsis. But then here you are, day 3, you see the patient's blood pressure improving. The cardiac output is normal. They look, their color is nice. Their white blood cell count is dropping. You read that on the paragraph. Okay, the white blood cells dropping. Um, so what would be your only explanation? That are they getting better? Yes or no?
Yes.
Of course they are getting better, but are they?
No.
No.
No. So this is what makes sepsis highly with a living sepsis with a high mortality, because we can miss this period here, misinterpret it to be an improvement. And once we hit septic shock, because this is the next stage, what does this say here, bio?
Even with appropriate intervention, the death rate among patients in this stage of sepsis is very high.
All right, so because what happens here is when you what will happen next once they hit septic shock is this will drop sharply. So this is now septic shock. Okay, so this is what makes it very deceiving. So therefore, what will be a better parameter? Do we only rely on MAP?
No.
No.
Okay, so these are the, of course, you saw how the management goes. Was it easy or hard to manage sepsis?
Hard.
It is
No,
hard.
very hard, very deadly, right? So therefore, we have to prevent it. So which patients will we prevent sepsis, or who will we monitor for the development of sepsis? These conditions listed in table 37. So this is a group of patients with either severe risk for infection, like that one, large wounds, okay, severe injuries, or very weak immune systems, like malnutrition, immunosuppression, people with cancer, people who are old, okay? And these immunosuppressed patients here, diabetics included because they are at risk for infection, plus poor wound healing. Transplant recipients, of course, they're on immunosuppressant drugs. HIV AIDS, I don't have to explain that. Okay, so these are your high risk population for sepsis and septic shock. They specified here, especially those with not only with reduced immunity, but who have central lines. Okay, they have an invasive line here, which is high risk for bacterial growth. Okay, so this is a big source of infection. Another are Foley catheters. Okay, they go uroseptic from those. So again, prevention is very important. So here, early detection is best in order to prevent septic shock rather than dealing with it. So how do we recognize it? Just read this on your own because most of our patients who develop sepsis are older people. So this is just what makes them more susceptible. Okay, so we already discussed these in the pathophysiology. I don't want to repeat it. Okay, they just this is a redundant section because we already discussed it them by stage. Okay, from early sepsis to SIRS to um, severe sepsis and then finally septic shock. We talked about ARDS in chapter 32. in addition to DIC, ARDS can also join the party, meaning the same, because the mechanism is the same. There was increased capillary membrane permeability in response to the inflammatory cytokines, and that will lead to accumulation of fluid in the alveoli, and the patient develops DIC. So 3 things can kill here: DIC, ARDS, or septic shock. So how do we monitor? So this is the crucial part. So nurses will have to monitor labs, and here no single lab test will confirm sepsis and septic shock. There are a few here, namely a rising procalcitonin level, increasing serum lactate. However, if you read down here, is the serum lactate the earliest to rise? No. Here, unfortunately, the lactate levels take time to change. Now, this doesn't mean they're not reliable. Okay, they're just not early or not sensitive indicators to watch for. So you have other parameters here. So instead of relying solely on serum lactate, which again takes some time to change, you would look at other parameters, namely procalcitonin levels, which are also mentioned here. And another one is activated, where is that? Oh, right here. Decreasing levels of protein C is evidence of the beginning of severe sepsis. Right there. So you have other parameters to watch for besides only your serum lactate. So you can look at procalcitonin level, and you see these tests. If a patient is admitted with SIPS or sepsis, or develop sepsis, let's say they're initially admitted for pneumonia and then they develop sepsis, you will see these tests. Doctors routinely order these exactly for the reason of watching for the patient's progression into sepsis. Okay, because again, once we're there, it's extremely hard to detect, and the mortality is very high. Since this is a serious condition, high mortality, the Joint Commission developed interventions, specifically core measure for sepsis. So they created Surviving Sepsis campaign, and this is the bundle, table 37-5 in this order. And it is divided into the time period. So within 3 hours of suspecting sepsis, and this one within 6 hours of suspected septic shock. So if we catch it early, these are our interventions. So draw lactate levels. This is the same blood test. So we draw blood for this before we start antibiotics. Okay, this is the same blood sample anyway. Lactate, just the different tube, and then this one will be 2 tubes. Okay, blood culture, and then you start your antibiotics, followed by IV. Again, when you read interventions like this, there is no hours between this and this. Okay, this is probably less than a minute. Probably longer for a student, but if you're an experienced nurse, you hang an antibiotic, it won't take you a minute to hang the IV fluid.
Do you hang them together?
Well, if you're the only one, then you hang this. Again, there's no big difference from when you hang the antibiotic to when you hang this. Do you get what I'm saying? Meaning it
Yeah.
yeah, it doesn't take long to hang an antibiotic and then hang an IV fluid. You get what I'm saying?
Yeah, I'm
Yeah.
saying that both are running at the same time.
Yeah. Okay, and then if they develop, you suspect that they're going into septic shock, then you add these interventions here. Okay, so now you add vasopressors. So we have IV fluids running here. This is a lot. Look at this, 30 ml per kilogram. How much is that if I weigh 70 kilograms? That's over 2,000 liters per hour.
2100.
A lot of fluids. If they remain hypotensive, because of course there's vasodilation here, right? So if they remain hypotensive, they don't respond, and then they go into septic shock, or you suspect they're going into septic shock, then you add vasopressor.
Vasopressors.
What's the vasopressor again?
So
Example.
Dopamine, dopamine.
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 What was the question, Joanna?
So can that be before 6 hours? Can they go into septic shock?
Yes, you don't have to. Yeah, you don't have to wait 6 hours. Okay, so if you suspect septic shock already, obviously that's progression already from severe sepsis to septic shock. It doesn't have you, meaning you don't have wait 6 hours. Okay, it just says here within 6 hours, this is still effective, right? It must be given within 6 hours.
Oh, okay.
All right. Yeah, don't wait. Okay, so this again, this is a range. Simply says within 3 hours, and then this one is within 6 hours. Of course, this one is the earlier stage, and then this one is now the severe. Patient's already in shock. And that's it for sepsis. Any question? All right, so for